Good evening, everyone, and welcome to this panel discussion titled Science and Public Policy, Pandemic Measures and Trade-offs. We're going to have a conversation about the measures taken by India to fight the virus and the social consequences therein. It has been exactly 1 year since India imposed a nationwide lockdown, and we have witnessed both hardship and grit in combating the pandemic. How well have we managed ourselves in our efforts to flatten the curve? And now that vaccination has been ramped up, should we be complacent in the belief that we are in the final leg of the battle against COVID-19? The recent surge in the number of infections suggests that we may be in for a second wave. So, how should we design evidence based policy measures? And what social factors do we need to keep in mind while implementing them? So that next time this year, in March 2022, we could be hopeful of at least being in the final chapter of the COVID saga. To help us understand these and other relevant questions in more detail and talk about the various kinds of challenges that lie ahead of us, we have four eminent scholars with us this evening. Dr. Anant Bhan is a researcher in the field of bioethics, health policy, and global health. He is a former president of the International Association of Bioethics and is currently an adjunct professor at the Center for Ethics in Yenepoya University, Bangalore. Professor Gagandeep Kang is a virologist and one of India's leading vaccine researchers. She is a professor in the Department of Gastrointestinal Sciences at the Christian Medical College in Vellore. She has recently co-authored a book on the pandemic titled Till We Win, India's Fight Against the COVID-19 Pandemic. Dr. Mohammed Asheel is a public health expert and the executive director of the Kerala Social Security Mission. He is also the executive director of the National Institute of Physical Medicine and Rehabilitation. He is an important figure in Kerala's management of the pandemic. Dr. T. Sundararaman is an expert on public health and health policy. He is a former professor and dean at the School of Health System Studies in the Tata Institute of Social Sciences, Mumbai. He is the global coordinator of the People's Health Movement, a network of activists concerned with equitable access to healthcare. A little bit about the structure. In the first part of today's event, which might last for 80 to 85 minutes, we will try to cover three main themes: trade-offs related to vaccination and access to vaccine, and trade-offs related to the healthcare system. I request the panelists to keep a time limit of around 8 to 9 minutes, at least for the first session, first round. But depending on how the conversation progresses, we could make changes accordingly. I'll be keeping an eye on the chat in Zoom as well as YouTube. And if there's a relevant follow-up question to what a panelist has said, I may direct it to them. Else, I request the participants to keep their questions for the Q&A session. We begin with the issue of vaccination, the trade-offs related to vaccination and access to vaccines. Now, I will be posing a question as we move to each panelist, but this need not be restrictive, and the panelists have the freedom to diversify and bring in relevant information from their domain of expertise. This being the first round, the panelists could also make any introductory remarks about the broad themes of today's discussion. All right, let's begin. Professor Kang, I want to start with you. We know that the vaccines are basically safe and adequately effective against the original strain and some of the variants. And there seems to be consensus that it is better to be vaccinated than not. Given the recent rise in cases, how do you assess the MHA directive of taking the second Covishield shot in 6 to 8 weeks after the first, when the WHO guidelines say that it can be extended up to 12 weeks. Dr. Kang.
So if we look at the data that are available for the AstraZeneca vaccine, it appears that the first dose gives you about 70% protection for up to 12 weeks. So if we accept that data, it seems to indicate that 12 weeks, if you get a reasonable amount of protection, then you are not putting people at risk by delaying that second dose. Now, there is a certain amount of confusion about what happens when you have a 2-dose schedule with varying intervals. Because if you look at the data from the first trials of the AstraZeneca vaccine that came out, those are the only ones where we actually have a difference in interval between doses. And those data seem to indicate that the longer the interval between the 2 doses, the better the immunogenicity, the better the efficacy. The only problem with those data is that actually 2-dose efficacy is just above 50% when the vaccines are taken as indicated, and then it starts to go up and reaches a maximum of about 80%. Now, why would 2 doses be less efficacious than a single dose? I think you do have to do a deeper dive into the data, which clearly demonstrate that the group that got the single dose and the group that got 2 doses aren't exactly comparable. So based on all the information that we have, we know that the vaccine works. We know that the vaccine protects with a single dose for up to 12 weeks. We know that if you extend the interval between doses, you get a better immune response as measured by binding antibodies and neutralizing antibodies. And you get greater protection against disease. So recommending a longer interval is not unsafe and may have benefit. And that benefit would be somewhere between 10 and maybe 20-30% of vaccine efficacy. That may not sound like much at an individual level, but it is a lot when you're thinking about a population, and particularly when you're thinking about the burden that can be placed on the healthcare system. Therefore, I think if we are to follow the science, then doing a longer interval is a reasonable approach to take, and many other countries in the world and the WHO have recommended that longer interval. Is it 6 to 8? Is it 8 to 12? Is it beyond 12? I think all those are really for expert committees to decide what seems feasible to them. It does look like 8 to 12 does give you good results, but our government has decided that up to 8 weeks is what is acceptable. And that's better than saying stick with the 4-week interval. So willing to accept that. The question about, given that cases are going up, shouldn't we be getting people vaccinated more quickly? Well, that would be a very valid question if the only schedule you had was a 4-week schedule. But I think we have not figured out how well these vaccines work yet. We have not figured out how long protection lasts as yet. I think we're going to have a lot more data to come in the future, and completely evidence-informed decisions will probably be even better made with more data. Right now, we are operating with the best we have. You're on mute.
Yeah, if I were to follow up, does the distinction that you've drawn between infection and disease have a bearing here? So if we are seeing increase in infection and not necessarily severity of the disease, should that give us some hope in saying, look, it is okay to keep the gap between the doses to 6 to 8 weeks?
Skip the doses part of it because I think we've dealt with that. But let's talk about the difference between infection, disease, and severe disease. Okay, so when you have a mucosal infection, it's very hard to prevent infections. Your mucosal surfaces, your nose, your mouth are constantly exposed. So finding a pathogen when you check out somebody's oral cavity or nasal cavity does not necessarily mean that they have disease. They actually have to have symptoms. And, with this virus and with other seasonal coronaviruses, we know that it's perfectly feasible to be infected and not sick. So when it comes to data from India, I think we need way more detailed data to be provided to us. We keep seeing the cases are going up, but the cases going up should also be tracked along with hospitalizations, which we don't do, and should be tracked with deaths, which we do. But deaths are a lagging indicator. A death will happen more than 2 weeks after the cases have been, after these people have been infected, right? So if you want to do a comparison between cases and deaths, the deaths today correspond to the infections that were there 2 weeks ago. So you can actually predict how many more deaths you're going to have looking at cases today, if those cases can be a good measure of asymptomatic and symptomatic disease. Unfortunately, that doesn't happen. So it becomes much more difficult for us to track exactly what is going on in terms of public health in our population. So if I was to take, there are lots of numbers that get put out, top 5 states, but the top 5 states have very different trajectories. You can't label them all the same. We're in a situation today that is very different from this time last year. The patterns of the pandemic are very different, and yet we are using that older thinking of saying wherever cases are more, there is more of a problem. That's just not the case.
Thank you, Professor Kang. Now let's move on to Dr. Sundar. Dr. Sundar, how can we improve our strategy of deciding priority when it comes to vaccine?
Yeah. Thank you for calling me in for this. Before I get to vaccines, I just want to expand the canvas of public policy, which we are talking about in pandemics. Getting into a very specific medicine to patient interaction and that core will miss some of the larger pictures that go around in public health and even macro global policy. There is a trade-off, for example, in the choices that are already made. For example, in urban development, between investing in urban infrastructure or whether you have put money into urban public health, whether you have put money into developing of health systems, whether we have invested in primary health care, whether with this whole free trade versus domestic manufacture, what is the level of indigenous capacity different countries have developed. So policy exists at one space, which is a much larger issue. Within that, if you look at the pandemic policy, each of these components in the decision on lockdowns, it's not only the question of in the question of social distancing, in test and track, in the hospitalization, access to hospitalization, and in vaccinations. Public policies play out in terms of giving rise to stimulating or riding upon past inequities in a major way. And somewhere when we are talking of public policy, I would like to look at the focus on what happens in inequities and look at growing inequity as a sign of systems malconfiguration, as you can say, rather than assume that, look, we've built a system, but what to do, it has an unequal result. So, for example, in the strategy of vaccination, to come down to a very specific question, I would have actually led with vaccination towards the end in the whole chapter of what we need to do about this. But if we were to start with that, the current rollout of vaccination has one priority to health workers, which is a consensus. It's a well-taken priority, and it's being reasonably delivered with all its limitations. There's no discussion about that. But the moment you go beyond that, the system is of actually registering on COVID, which will sort out your priorities, and according to those priorities, people will get vaccinated. Now, that's a really flawed system. Part of the glitches of the COVID is the least problem. The problem is that much of it, the access would happen. In fact, many people don't even use the COVID. In practice, what is happening is walk-in basis, most private hospitals are offering the vaccine, and as a post hoc, after the vaccination, they enter it into the COVID because it does come with a vaccine certification, which is useful, and also for many reasons, they enter it in afterwards. So COVID doesn't actually even lead to sorting out even the access that the most influential people have to it is very limited. But the real problem is when you're talking of prioritization, it's not only on medical prioritization. It is also on degrees of vulnerability. Degrees of vulnerability and consequences of the disease and consequences of the nature of response to life and livelihoods in different sections. And therefore, the priority of vaccination must often and must necessarily adjust to vulnerabilities beyond comorbidities by occupation, like health workers we recognize. But for example, during the lockdown, we came down on certain sections, vegetable vendors, coimbedu, fish vendors, we came to certain types of occupations, sanitation workers, we came to number of occupations, people using public toilets, prisoners. All of these we defined as highly vulnerable categories. Now, what exactly is the strategy to reach out to these people? Is there a disease prevalence in them? Where is the strategy of reaching out? This is not going to be walking into a leading corporate hospital just because it's been made available. They may be the rickshaw puller just outside, but he's not going to. And when you are talking of opening up the economy, which is equally insistent, opening up their income and livelihoods, prioritization has to be done. It will require very intensive public outreach programs. And in fact, it will need to actually engage with employers, it will engage with trade associations, with associations of people to be able to identify groups within which we have a greater risk by social condition as different from purely the medical condition and be able to reach these out in a major way. Now, we do know, for example, in child immunization that many children get left behind and we have programs to move to that. And to shift that same infrastructure into mobilizing for COVID-19 would be really painful because it would deprive, weaken your basic health programs, which we've already done in one of these unpardonable trade-offs in many of these issues has been that. I do not agree that it was necessary. We have just published a number of best practices where they were able to manage a COVID response without such a trade-off. But therefore, this whole issue of vaccine prioritization is closely related to the strategy of public service delivery as different from just making it physically available in a number of facilities where people who have Now, this is the paradox. It's been called by Tudor Hart a long time back as the inverse care law, that the most people who are the most vulnerable, who need it the most, often have the least access. So precisely many social segments which are in great need are likely to actually not reach out or access this. And therefore, the role of strategy in delivery of vaccines needs to consciously address this inequity. And at some point, I think this whole factor of how inequities play out has been poorly understood. Other than when I come to the next thing, we'll come to the issue of stigma and denial also as it plays out on this. Thank you.
Thank you, Dr. Sundararaman. Now let's move on to Dr. Bhan. Dr. Bhan, what are the ethical challenges involved in a vaccination drive, the magnitude that we are seeing in India? Over to you, Dr. Bhan.
Sure. Thanks, Don, for also having me on the panel. So a few things, maybe, just adding on to what Dr. Sundar was saying, one of the things which, and because many of you are also philosophers, I think what might be also of interest is, when you have any prioritization exercise and you have a priority setting process set in, and it's also important to talk about what was that process, who was involved in that process, and how did they come up with a set of priority groups. So we know in India, for example, there was a decision made. What we don't know is what went into that decision making. They did end up deciding that yes, healthcare professionals, frontline workers, those above a certain age and those with comorbidity would be our priority groups. But we have no idea what kind of frameworks were used. Were these purely risk-based frameworks? Were they age-based frameworks? Was there a decision or a discussion which looked at other priority groups at all? Did they look at any ethics frameworks? There are many ethics frameworks, for example, available from past experiences of dealing with pandemics, including the flu pandemic specifically. And many of these are global in nature. But since we have no idea how that decision was taken, that is one of the issues that is also worrisome, because from an ethics perspective, as much as decisions are important, the process involved and transparency of those processes is equally important. We also need to know who are the groups involved who are taking these decisions, what are their mechanisms for public appeal, for example. You might come up with a set of decisions, but then I, as a citizen, can I engage with you and say, I feel that you should have also had another group. As Dr. Sundar said, it could be sanitation workers, for example. It could be people who live with HIV. It could be trans persons. But how do I engage with that group which is making this decision if I don't know who that group is and I have no public platform where I can provide feedback? So I think that's certainly been a gap area. And from an ethics perspective, that is worrisome that you have a decision made and yet there are no mechanisms for appeal or to engage with those groups. Because at the end of the day, everyone had to abide by it. It's not like you had a way of going around it and being able to access vaccines. The second element is where are these vaccines available? Who has access to information about accessing vaccines, and who's able to then go ahead and reach the centers where vaccines are being provided, because they're still largely facility based vaccination efforts, right? So whether it be urban areas or rural areas, I pass through a public medical school often, and it's usually older individuals who are middle class. I don't see a lot of individuals from lower socioeconomic strata who are able to access the vaccines. And this is a public center, so the vaccines are actually free. The corporate centers, it's likely that only those who are coming from a certain socioeconomic strata are walking in and getting the vaccines. And if this is true, I might have a bias here because I'm only looking at one or two sites, but that's the sense I've been also getting reading, sharing by other individuals, that there's not a lot of people from those who might be coming from poorer sections, those who might be coming from inner city populations, urban poor, who are able to access the vaccine, even if it is free. And so if that is true, then what is that indicating? It's certainly indicating an inequity of some kind, but it also tells us that there is probably not an informational issue to it. The fact that you are required to either register on a platform or turn up at a center and wait for your turn might mean that individuals probably don't have access to that information or adequate understanding of that. This is a vaccine which is available for everyone. They can go and access it as a government service. It's also probably linked to the fact that there are hardly any services, especially for older people in our health systems. Geriatric care in India has not been given a lot of focus. So, the fact that you suddenly come up with an immunization program when geriatric care has not been given a lot of focus on historically also means that maybe there are not enough touch points. So we don't really have a tabulation often of who are the people beyond a certain age group in our communities who we could reach out to. Now, there are probably exceptions. There are some states with better systems, but a lot of other states without those systems. The other thing is, from an ethics perspective, would be the issue of choice. Now we have a situation where at least we have more data available on both vaccines. But earlier there was when the vaccines were launched, there was not enough data available on at least one of the two vaccine candidates. Actually, for both vaccine candidates, with Covishield, there was not enough data on local from a local perspective because the local bridging studies were ongoing. We still don't have that data in the public domain yet. And with Covaxin, we just had a decision without phase 3 data. There also we're waiting for the data. So, should people then have the choice of deciding? And if not, what does that mean from a risk perspective and from an informed consent perspective? Because in one of them you have to give consent, but then how was consent taken was also a question mark. If you don't have a space for engagement, if I walk into a center and I sign a form, that is one thing, but that is not necessarily consent. Was there a private space where I could have a conversation, where I could ask questions and then make an informed decision? But if you don't have a choice, the only choice you could make is not access the vaccine. So that also, I think, is an important ethics question to ask. But what we should worry about is certainly the larger question of equity. And I think that, for me, is going to be something that we should engage more on. Whether we talk about vaccines, whether we talk about testing, whether we talked about the kind of random testing which is happening in cities like Bangalore, where people at bus stations and railway stations are being tested against their will. Would those standards apply in the legislatures of our country, or in political rallies, or in religious processions? And if not, why is it that those who are easy to round up and and you enforce these kind of measures against them, why are these kind of measures not taken against other sections of the population who might be more well connected or politically well to do, right? And what does that tell us about the way we treat our citizens? And isn't that an ethical issue? Coercion of any kind, is that something from an ethics perspective should be considered acceptable in public health? And what does that do to trust in public health efforts? So I think, that'd be another example of an ethics issue that we should talk about. But I'll stop here maybe so that we can continue the discussion.
Thank you, Anant. Now let's move on to Dr. Asheel, who might be able to give us a good picture of what's happening in Kerala. Dr. Asheel, are there iniquities, as Dr. Bhan just mentioned, involved in who is getting the vaccine first? What are those iniquities, and how do you think we can nullify those iniquities? Dr. Asheel.
In continuing to what Sundararaman sir has just mentioned, that our entire view of seeing this pandemic as a kind of just a medical issue or a public health issue may not be actually giving the whole picture. COVID-19 is not just a medical issue. It's more of a socio-economic, political, and more of a humanitarian issue, just not a medical issue. So if you take it that consideration, every single action you take, whether it be the lockdown, whether it be the medical intervention, whether it be public health policies, everything should actually take into the consideration that this is just not a medical issue. If you take that thing into consideration, then only I think we can actually address these things. Let me put it very pragmatic. Already, many of the aspects have been already mentioned. So let me look at the very practical aspects of that. For example, we were trying to when the vaccinations were scheduled and when the vaccines were allotted for the states, we were practically trying to address the areas which are more vulnerable. For example, even among the citizens above 60 years, if you see there can be many other compounding vulnerabilities. For example, tribal above 60 years and tribal transgender above 60 years is more vulnerable than just a person above 60 years who has an access to IT or access to kind of mobile app. So what happens is that for just for a practical example where we have actually faced a predicament is that we thought of vaccinating all the destitutes first. So we had around 3,800 destitutes under us, under our homes, like we have destitute homes. But what they don't have is a photo ID. So we don't expect everyone to have a photo ID. So that photo ID is a block here. Actually, you need to get a photo ID before entering into the software. One. And we can actually you need to have a mobile number which gets registered with which you can register only 4% through one mobile number. So this was discussed at the review meetings with the government of India, and it was decided that through one mobile we can register maximum number of people. But that was yesterday it was taken back. So now what happens is that when we go for vaccinating in care homes, for example, we have around 619 care homes where 20,000 elderly are there. So why we actually focused care homes is that if you look at the data from UK, around 1/3 of the deaths in the initial 30,000 deaths, 1/3 of the deaths occurred in the care homes. So this is an area which we need to address. So we thought of vaccinating the people in the care homes. What happened is that, again, the problem of whether the people in everyone in the care home would be having a mobile number. If at all, what we need to do. So the registering them with a mobile number, maximum 4 people can register. So which means that we'll have to take another 5,000 mobile phones to getting vaccinated for 20,000 elderly in the care homes. So similarly, the issue comes here is that as Sundararaman sir has just mentioned, and many of the panelists have already touched upon, is that there are many factors in this, and the states have actually different types of capacity, different types of strengths and weaknesses. So that kind of freedom need to be given. I'm sure that Sundararaman sir would be able to describe that, because I have attended few of his training when he was heading NHSRC. So we were thinking of MR campaigns, this measles rubella vaccination campaign. So measles rubella vaccination campaign, when that came upon, the states were given the whole freedom to do that. And similarly, states are doing vaccinations on a large scale. For example, for polio vaccination, crores of children, millions of children are vaccinated in the states. So what happens is that the priority, the more equitable distribution of this and the ethical considerations of this can actually be done at a decentralized level rather than a centralized level. So I think the primary unethical, the ethical consideration in this whole vaccination thing is a mobile app driving the entire campaign may not be an ethical, I think is the major ethical concern here, because on a practical issue, there can be many other issues on many aspects, but on on-field, the issue happens is that an IT-based mobile, and there obviously the digital gap is also huge. So you need to vaccinate on it if there is no offline option for this. So if you need to vaccinate if you are going for in a rural place, but thankfully almost all part of Kerala is having an access to internet. But still, what happens is that there can be places where the internet access is not there. So there is a systematic deprivation of the people who are inaccessible. And I take the word from Sundararaman sir that inverse care law is practically being that's a classical example of inverse care law, where the people with access to computers, with access to mobile phones, have a higher chance of getting the vaccines. And also at the same time, even if you are well to pay, you are given the same option. That's another whole set of another ethical consideration, that if you can pay, then you get access to the private hospitals where you can actually pay and get the vaccine. 250 rupees, you can pay 250 and get the vaccine. So what happens here is that you get a priority in getting that. So why can't we do it in a line where we have done many vaccination campaigns? It's not the first vaccination campaign. Obviously, it's maybe the biggest adult vaccination campaign. But when you look at it in another perspective, the states, if given the freedom and directed to give it a more equitable and considering all the ethical aspects, I think that would be a better way to approach. So just being critical in that, though part of government, I think this forum have the freedom to do that, and as the experts are here, so just opening up my mind in that you don't have other place to open that. Thank you.
Thank you, Dr. Asheel. We are keeping good time. So in the next part, let's take this a step further, because we've heard about the medical frameworks, the socioeconomic frameworks, and now we'll see how we can build upon it. And let me start with Dr. Sundar. Dr. Sundar, how should we evaluate the response, India's response to COVID-19? What would you suggest? What kind of cost-benefit analysis should we be looking at, Dr. Sundar? Dr. Sundar, you're muted.
I wouldn't enter into cost-benefit analysis. There's a little way of either costing the expenditure or the benefits out of this. And but there are certain, let me say, the fault lines, the basic issues. We had a very vigorous response, very. That is not enough to make it an adequate response. The real problem of our response from an ethics viewpoint is that at some point, we did not really care about the well-being of the majority of the population. We treated people more as vectors of disease than as individual rights-bearing citizens. And the entire range of measures that we brought into place was in some sense bereft of this particular nature that we will need to actually weigh this in. Let us take the classic and the most prominent of it, the lockdown. Now, there are countries that have managed without a strict lockdown. Could we have? There is an issue there. But what really informed the nature of restrictions, what informed the nature of relaxation of restrictions, what informed the fact that migrant workers, for example, deprived of a job but shut up in shelters, confined in enclosed spaces with least movement, could incubate disease in a major way before they moved on it. You see, we have, it's not new. The pandemic is not new to the world. We have for more than a century, we have an epidemic disease act of 1897 that's been amended recently. We have a National Disaster Management Act. We have an international health regulations that builds up preparedness. All of them seems to have lost one particular aspect, that whatever we do plays out very unevenly and very unfairly, and there are no systems at work to ameliorate, to mitigate what pain and suffering is caused to the weakest and most vulnerable on that. That, I think, is a condemnation of what we are. Look at the way we went about creating extra beds. We were first told we are creating 1 lakh extra beds. And then what did it turn out on closer examination? Some of the busiest public health hospitals were repurposed to become COVID-19 hospitals. Cannot avoid naming Jipmar on that. There are hospitals that do 8,000 outpatients per day, 6,000 of them cases, some of them are primary care, but they don't have primary care for hypertension or diabetes around, they land up here. But they do even liver transplantations, they do a whole lot of surgeries free. That becomes such a big, busy public hospital, district hospital, subdivisional hospitals become repurposed for COVID-19 care. That entire population that has been dependent upon that hospitalization care gets dumped. Now, I don't see this as a necessary cost-benefit analysis. We did some good case studies for WHO, and there is, for example, one in Biratnagar on the Nepal-Bihar border, a major maternity home and general hospital where the leading medical superintendent, perhaps because she was so far away from the centers of power, managed to actually integrate both care so that we did not shut down a single service. He was a gynecologist, very driven by her patients. And she knew that she couldn't manage it without managing COVID at the same time. And therefore, they would manage it very adequately. The problem is, very often we look at public care, though in theory we say a lot, as something, the public hospital as something taking care of those diseases and of those patients who can't afford private care. It's in the classic American term, residual care, for those people whom the market cannot take care of. So it may be a disease like leprosy. It may be HIV, which is very strongly seen in the public sector. It may be drug-resistant tuberculosis that does not happen. So these are diseases, and net COVID-19, which at some point, this care is not attractive for whatever reasons to the market. And it is also certain people who are too destitute, too dirty, too poor to be actually seen, having no attenders, homeless people alone. And these get into this. So therefore, it's a sort of natural consequence that when you have a certain higher degree of stigma and a higher degree of unwantedness about it, you are able to actually shut down the services of a lot of government hospitals and repurpose it. Now, this was not necessary. There were underutilized private sector hospitals which have been having problems of that, which could have been brought under public authority. For COVID care centers, government did a remarkable job, especially in Tamil Nadu, and a lot of it is based upon our activist experience with the Tamil Nadu Science Forum, the studies we have done in 13 districts. But the COVID care things, when they brought in engineering college hostels and community halls and different hostels and made them very good isolation centers, was well done. It really was able to build capacity without shutting down, without having to trade off versus other essential services. But this was a very thoughtless service. Even on restrictions, how much of these restrictions is based on scientific policy or how much of it is an administrative law and order mindset? I still, and can't help asking a direct question to Madam Gagandeep right there, is what is the science behind the night curfews? Do viruses become more dangerous in the night? I thought India was foolish in it, and then I heard Denmark also did it, and I got properly confused about it. So I find many of these restrictions so coming out of law and order curfew, because there is riots going on in town, has a certain logic. You open the shops for a certain small amount of time. You do that in COVID-19, then there is a rush at that. You open it for 2 hours, there's a big rush for that 2 hours. So actually you defeat the social distancing that would have occurred if you had kept it longer hours. Why ask everybody to shut down? Why prevent people taking a walk on the path? So a whole lot of these restrictions were thoughtless. It did not matter so much to the middle class. They had mental problems, they had their own angst and anxieties. But to the poor, for whom it was survival was dependent upon that, where day-to-day business, where there was many expert committees that ruled. I say with great shame, with a number of leading medical scientists, that public toilets must be closed down because they are a source of infection. They said that in all seriousness. Karnataka, to name one, for example. And where would people go in that slum? And in the Chennai city, they put iron frames and grills on the door so that people could not leave their houses. And they didn't have a toilet in the house. So in some sense, you are really talking of a certain law and order mindset that under the National Disaster Management Authority, the security apparatus took away much of the functions that should have been led by public health. And what characterizes it is to see people not as the sovereign, but to see them as a subjugate thing. So that's a basic mindset of whom you are ruling for and who you have to preserve. This was there in the messaging. This was there in many different forms in which it plays out in many of these things. One particular correlate of this is the criminalization that occurred of those who were transgressors in some way, whether of a lockdown rule or of a social distancing or whether of access to treatment on this. You had a certain, and that leads to a very interesting complex of both stigma and denial. Stigma is, I refer to feeling ashamed that you've got the illness, hiding the fact that you've got the illness, and isolating or ostracizing another person with the illness. Denial, and that you do because you say the disease is deadly. And you mix it simultaneously with another collective attitude which says, oh, there is no disease at all. It's a bekar hai. People, the government servants are unnecessarily registering cases because they are getting incentive money. It is very commonly told in our villages in Tamil Nadu. It's a bizarre lie, but at some point people believe it as the truth because there is this phenomena that the disease actually doesn't exist, and we have denial of the pandemic, going along with the worst of stigma. What it does mean is, when it comes to something like access to testing, even though India did a remarkable job in the scaling up of manufacture, truly remarkable, much more impressive in some ways than vaccine. We were manufacturing 1,200 RT-PCR kits in March. We are per day. We are manufacturing 1.2 million kits per day today. We had a testing capacity of a couple of labs. We have a testing capacity of 2,700 labs. But again, if you look at it from the lens of inequity, a district like Perambalur in Tamil Nadu will have a much different thing from Chennai. And you can identify that by the ratio between how many are expected positive by seroprevalence and how many are actually reported positive. Now, there are many factors why there can be a gap. But in Chennai, it's a 1:9 ratio. In Perambalur, it is a 1:149 ratio. In Ramanathapuram, it is 1:88 ratio. In Kadalur, it will be 1:39 ratio. So you will find that the actual access to testing goes very much regarding the level of development and backwardness. This gap between seroprevalence is the health development, the backwardness of health systems development, not necessarily of people's consciousness and that. And how do you actually correlate it plays out, how stigma plays out, denial plays out, and this needs to be actually studied. But the fact is that there is, even in testing, where we have done remarkably in scaling up domestic manufacturing, truly remarkable, still, if we had a different lens to see it, we will see that actually this could have been avoided, provided we had this much stronger commitment towards equity. And for many reasons, test positivity rate is not at all a very useful indicator. The way it is cast now, where all the denominators are gobbled up and all the different things, you can't look at it. So all these poor performing districts have also poor case reporting, high gap between seroprevalence, but also very poor test positivity rates. So in some sense, you need to actually interrogate this, and we need much better data for it. So in short, what I am saying is that inequity, there was a vigorous response. This response was largely satisfactory if you are looking at one segment of the population, those who could stay at home and continue earning or had adequate social security to protect them. If you look at this subpopulation, we can say we did a good job. And many responses to our good jobs comes from this population for whom it was really a good job. But if we look at the way lockdowns played out, testing played out, contact tracing played out, hospitalization played out, access to non-essential services played out, and now access to vaccination is playing out, it has actually missed about 80% of the population or put them into an unreasonable and unnecessary level of suffering. That, I think, is the problem. It depends upon which India you're talking about when you're talking about how the policy played out. Yeah.
Thank you, Dr. Sundar. Dr. Bhan, maybe this is a good follow-up to what we've heard from Dr. Sundar. India seemed to have done relatively well. We avoided a public health disaster. And at the same time, there seems to have been all these worries about socioeconomic factors. How do we place them together? I mean, how do we make sense of this unevenness, Dr. Bhan?
Sure, Don. So I think, whenever we talk about public health, we have to recognize that, it's not just about disease or prevalence or, or vaccines or interventions. We have to also recognize that there is a social element to it. And I think Dr. Sundararaman very succinctly pointed out some of the complications we saw in the way we responded during the pandemic. So the onus of the way the response happened often fell on communities which just were not prepared for these kind of a circumstance. So when we took decisions like lockdowns, then what did that mean for communities, especially where there were a lot of daily wage earners and in urban settings? And the way we responded to them, the way we stigmatized interstate travel, for example, the way we treated our migrants, the kind of visuals we saw of people being lined up and then being sprayed with disinfectant or bleach, in a totally inhuman manner, tells us something about the way we look at segments of our society, and that I think is deeply worrisome. The second element of that is, could we have prepared better in terms of knowing that this is going to happen when you take a step like a lockdown? And I've had this feeling all throughout the pandemic response that part of the challenge is that in many ways our response has not been essentially driven by public health leadership, especially within the government. It's often led by, say, the home ministry, or the police department, or the law and order machinery, or it's the collector's office, which comes out with all of these directives around things like night curfew, there is no evidence. But it is what I often call a danda response, which is to say that, we treat everything as a law and order issue. We don't necessarily look at the public health implications of these decisions and also whether they make sense from a public health perspective. So are we really leveraging data, and are we really leveraging evidence effectively in our response? To some extent, probably yes, but in many ways, I don't think so. I think it's still, and the laws are also in some ways archaic on that. The amount of power that they give authorities without the need for accountability is certainly worrisome, because what mechanisms do you have if someone comes into your household and does forced testing, or puts on a notice outside your house saying that you're quarantined? And imagine the stigma in the early months of the pandemic, when many households were basically labeled, or people were stamped on their hands, and and all of those kind of things which were happening without probably an understanding of elements of public health. And I think that is one element. The other element is, what did this pandemic and the response to it mean for routine services? Whether that be midday meals at Anganwadis, when Anganwadis were shut down, whether it be social interaction, access to education, especially for children from low-income communities, and even within that, girl children. The fact that you shut down schools and then you had the only mechanism was online schooling. So what does that? What are the implications, and are we really tracking those on kids who have dropped out of school? The long-term impact this will have on our societies, on the impact of isolation on young people, and the impact it will have on their mental health and well-being. And what kind of services did we have to respond to that? And I see that there are gaps probably in all of this. Now, there are also good models of response where community, local self-governments stepped up to the plate and ensured, for example, local supply of food, or ensured that there was a health worker going out and meeting elderly people in the community who were living alone, and trying to find out about their well-being, or offering support and information. But there were many other areas where probably that information was lacking and that support was lacking. And I think the implications of those are certainly worrisome. In fact, there is data often now collected by community-based organizations which indicates everything from antenatal care to immunization to institutional care for conditions, to availability of blood, availability of cancer care, many aspects of what you would consider critical public health functions, all of those suffered. And now with the increasing number of cases, if we again see an overt focus on COVID-19 care at the cost of other kinds of care, we might be again seeing a health system which already is overburdened, but then is burdened primarily with one kind of disease response, without recognizing the need to also ensure that there are critical functions for other responses, including vaccine preventable diseases, vector-borne diseases, etc. So I think that tells us something about the fact that our health system, perhaps sometimes also one is not resilient enough to understand the need for looking at things beyond just testing and medicines and vaccines, but to understand some of these social determinants that also within departments we don't often have an understanding that there is a need for a coherent response, where WCD, nutrition, health and family welfare, education, all of them need to work together. We just don't have that kind of governance mechanism where people work together across these departments. And then you have obviously a situation where the impact of the pandemic will be much more severe on certain communities and families. And those who are already historically marginalized would have borne the brunt even more. In fact, we have just about started a research project uh, with trans community members, because we've recognized that this pandemic has been very, very traumatic in many ways, and has just exposed the already stigmatized way in which they access care, and the lack of services for these kinds of marginalized communities were really worrisome. So we need to document all of that, and I think all of us have a role to play. But at the end of the day, even if we document and we have these conversations, unless we see reform happening based on that, unless we see policy understanding of these kinds of trends, I worry about, what are we better prepared in a few years to another pandemic? There probably are more pandemics coming, but what will we do differently is hopefully what we should also talk about. Thank you.
Thank you, Anand. Let's move on to Dr. Asheel. Dr. Asheel, you mentioned about the mobile app, and it seems like we've been on this technology intensive approach. But even considering all that, have we adequately collected COVID data and made use of it in evidence-based policy? Dr. Asheel.
I think just looking at the usage of Arogya Setu app, I don't want to comment on that, like, literally, because I have been involved in the COVID control program in the state, and I have never seen anyone using Arogya Setu app for anything. So especially for tracking these things. So I rest my case with that, because Arogya Setu, even after collecting the data through Bluetooth mechanism to GPS, everything, which seems to be the ultimate solution for tracking your contacts, tracking your all these things, and later we came to know that in a parliamentary question that government is not sure who made this app. There was an issue on that. So I'm not really commenting on much more on that. So like, that's my case. So when you look at the digital technology, whether that has been used, if you look at, there are examples in the world where digital technology has been effectively used. But still, the countries have something of common in them. That is, they have kind of a authoritative kind of governance in there, where your privacy is secondary to the entire issue of public health. So, and again, coming back to as what Anand sir has now pointed out. So when we deal the pandemic, we need to have a kind of convergent approach. As I mentioned earlier also, it's just not just a medical issue. So we need to go to all aspects of that, especially when it comes to the socio-economic and the vulnerability issues. For example, when the initial planning was happened, one of what we tried out in Kerala, I don't say that it's perfect in that, but what we have tried out in Kerala is that in the beginning, in the month of April, in the ending of March itself, when the lockdown was declared, the deliberate efforts were, there was a committee constituted to see that the people who are vulnerable, who are marginalized, are not getting more marginalized. So, there should be special focus on people who require special focus. That's exactly to put it like that. So there must be deliberate efforts. In that aspect, what was done is that if you look at the primary social factor or the immediate factor in which these vulnerability reflects is with regard to availability of food and basically the starvation and hunger issues. Even in the beginning of this pandemic, somewhere around in April, the World Food Program said that there would be around 270 million people going for acute hunger, acute hunger due to the effect of this pandemic. So that is something very seriously concerning. And now looking at the data after 1 year, there is a beautiful report which is again put out by the World UN Food Program, which says that 3,900 crore, that is 39,000 million midday meals were missed by the children during this, missed by the school children during this, because schools are not happening across the globe. So this was a primary concern. How did the state try to deal it is that in the beginning of April, what we tried is that just the end of March, when the lockdown came in. What we tried is that we started community kitchens. That community kitchens, 1,034 community kitchens were started, which and around 37 lakh, 36,000, 36 lakhs 56,000 this cooked food meals were served. Of which 75 lakh were actually 75 lakh means 7.5 million cooked foods were served to their home delivery, served as home delivery to people who cannot actually cook. Then after that, every month we have been giving to around 88 lakh households. We have been giving food packets. Food packet in the sense of raw materials, of which 17 items would be there, including cereals, pulses, and all those things, including oil. So that was given to ensure that people are not going for starvation. And the relevance of that report is that, as many would be have already noted, there is a study which came out which said, which is known as the Hunger Watch survey. When you look at the Hunger Watch survey, which was published, it says that in India, when 11 states, when the study was done in 11 states, they found that 21% of the people who are participating in the survey reported that for the first time in their life, they have experienced starvation during this pandemic. 21% is a big number. 21% of the people who have experienced starvation, and starvation in the study is defined as a situation where you don't get a single meal in a day. And 57% of the people who participate in the study from the 11 states said that they had to significantly reduce their food intake during the lockdown and in the issues and post-COVID situation. So these are the things which we need to focus, because as I said earlier itself, this is not just a medical issue, it's a more of a socio-economic and a humanitarian crisis. Just looking at the hunger, I have just touched the hunger part. And at the same time, there, as Anant sir is beginning to say, that with regard to the transgenders, when we have around 25,000 registered transgenders in Kerala, where we try to actually support them during this pandemic through kits and through food kits and many other mechanisms. But still, what happens is that the area, the profession which they were involved, the occupation which they were involved earlier, many of them actually lost that. So what happens is that there is a systematic deprivation or kind of a taking away their jobs. So what happens here is that not only the transgenders, the persons, the people in unorganized sector, informal sectors, and also the people like which are particularly vulnerable, like tribals, like persons with disabilities, all get more marginalized. So what happens is that we need to focus on each of these categories. I just mentioned on one of the category with regard to hunger, and there are many other social issues which was supposed to be deliberately intervened, and the state has done few actions in that. I'm not explaining the details of that. The other part, when he says that the elderly, when you say the elderly, I'm just saying about in my state there is around 48 lakh. There is 4.8 million elderly people here, above 60 years, and Anganwadi workers, as Anand sir has said, the ICDS is a good area to intervene at the local level. So what we have done is that the ICDS worker, that is Anganwadi workers, followed up each of these cases. 45 million and 4.5 million elderly was followed up, and identified that 2.5 lakh, that is 0.25 million of the people were particularly vulnerable. And we established 14 call centers, one in each district, to regularly follow up these cases, to regularly follow up these elderly who have particular needs. And also there are psychosocial support, just to say the scale of the psychosocial issues involved. We started a program exclusively for COVID-19 during this, and the psychosocial need or the calls which came for psychosocial support was around 7.5 million calls have come for psychosocial support. Of his around 1,000 cases, we actually went for giving medical support, that is pharmacotherapy. Many were put on counseling and everything, but around 1,000 people, we actually went for pharmacotherapy just out of this COVID-19 issue. So I was just mentioning the thing. So what is, if you look at COVID-19 as just a medical issue, it was actually just a tip of an iceberg. There are much more things beyond of that iceberg, beyond the horizon.
Thank you, Dr. Asheel. Certainly, the trade-offs related to pandemic policy and governance are indeed difficult and controversial. Moving on to Dr. Kang. Dr. Kang, is the 3T protocol of test, trace, and treat being adequately implemented, especially in hotspots? And when can we expect herd immunity?
Okay, so test, trace, and treat, or test, trace, and isolate. Forget the treat part of it because that's a different arm of the healthcare system. If you don't do it well, should you do it at all? Is my question. And at what stage should you think, okay, I don't know whether we should be continuing in a particular area or not? If you have a small number of cases, then it's something that the healthcare system can handle. You can identify people, you can trace their contacts, you can make sure that they are isolating. So either you need the manpower to be able to implement it, or you need people who trust the government and follow what the government tells you to do. Once you get beyond a certain point, I'm not sure how much sense an inadequate testing, tracing, and isolating protocol really does to arrest a pandemic. Add to that converting, using this testing to convert something that is a public health issue into a law and order situation, coming up with innovative hypotheses for what might be measures of control that rely on behaviors of the virus or of populations that we've never heard before. The night curfew is one example of those. I think for a lot of testing, we should know what we are going to do with the data. And all too often, that does not happen. We test because we've got the protocol in place. We are continuing to identify people without knowing how we are going to be able to handle any component of control of transmission. About herd immunity, I think herd immunity, whether you get it by infection or vaccination, we will need to see how this plays out for this virus. It was an interesting concept to think about. It's certainly a concept that applies very well if the herd is a closed group. But if you're going to have in-migration and out-migration within that group, then herd immunity as a way of decreasing transmission becomes harder to handle. The other aspect that leads to questions about herd immunity is the fact that there is so much heterogeneity and spread. If 80% of your infections are coming from less than 10% of the infected individuals, then how is herd immunity going to play out? What you've really got then is a situation where you've got multiple super spreading events happening very frequently. So will we achieve herd immunity? I'm not clear about that. I don't know what is happening in terms of what the government is planning to do for herd immunity, given that we have a statement that says that only 30% of the population will be vaccinated. How we expect to get to herd immunity with that isn't clear to me. And then when you have variants, then do you need separate herd immunity, separate exposures to each of the variants to whatever magic number herd immunity is supposed to kick in at? I think I still have a lot to learn about the virus and the populations that it's infecting.
Thank you, Professor Kang. I think we have time for one last very short session, and I would request panelists to keep your responses to within maybe 3 or 4 minutes. And because I want to talk about the trade-offs related to the healthcare system, and in particular about vaccine research and pharmaceutical companies. Dr. Asheel, it seems that we focus too much on COVID-19, but if we were to ask, look, for a robust healthcare system, healthcare system to address the medical needs of the population, what needs to be done?
Robust health system, as Sundararaman sir has already said. Before that, I must say that when Gagandeep madam said that she has much to learn about the COVID-19 virus, it seems that like yeah, far to reach to anywhere, because what we learn is from people like Gagandeep madam that what we know about virus is if madam, when madam says that we have much to learn about the virus, I think we are far away from reaching adequate information. One thing is I think Gagandeep madam, if time permits, please explain on the fact that how do we see that the strategy of vaccinating a 30% population against the strategy of the herd immunity. So there was a lot of discussions happened earlier that and this 30% of the population, which is coming around roughly around 30%, it's just 30 crores actually. So when that population is addressed, that's a population who are more vulnerable, who are more chance of dying due to COVID-19, and who are more chance of spreading. It was told like that. I'm not sure about the spreading part. So how do we see that against the strategy of herd immunity? Whether the strategy of countries like Israel, where they went for practically for a herd immunity strategy, against the strategy of addressing the population, most vulnerable population, what would it weigh, if you weigh the evidences? What seems to be more practical? Can I take the flexibility of asking that question now?
Sure.
Okay.
Yes, sure, Professor Kang, go ahead.
So, in terms of policy and vaccination, what is it that we are looking to achieve? Are we looking to protect the most vulnerable from severe disease and death? And if that's our goal, we will be done with the 30%. But if we are looking to control the pandemic and decrease transmission of the virus into places that may be less affected or populations that are less affected, then you need to be vaccinating a much larger proportion of the population or letting them get infected. So our vaccination strategy has to depend on the goals that we have, what we expect the vaccination to do. And I'm not sure that we have that, because if you look at the 30% strategy, I think the decreasing mortality will be done if we manage to get that 30% done and done well. It's not like there won't continue to be cases, spread of disease or deaths, but they'll be in populations that are at much lower risk.
Yeah. After you finish.
No,
Please.
pretty much. The goal is to stop transmission. You have to vaccinate more people. And I've never seen in our country a vaccination program that has been based on your risk group. The only place where we've had differential vaccination in India in the national program is for Japanese encephalitis, where it is a geographically defined risk. And this is a whole different ballgame, so I don't understand how the policy has been made.
So,
Sundararaman, do you want to? Yeah. Please go ahead.
I just wanted to make 2 points. A point which I made in a recent Times of India interview also, which I had made. You see, there is one particular right that comes into place. If the vaccination is a cost-effective way of protecting me or my family member from getting this disease, and this disease is not just another flu, that denial of that disease, we leave it, if you get it, the risks are there. Then at some point I have an entitlement to it. It's a cost-effective thing in the notion of universal healthcare. So, which is a different proposition from saying, should I have a public health campaign to ensure that everybody is immunized within 1 year. But there is a simple entitlement, at which case in an informed way, people must be able to make that choice. There are a lot of people who, by virtue of their occupation and life situation, are highly vulnerable and must be able to exercise that choice. That must be a foundational principle on which any treatment is based. If I have got a particular risk of getting hepatitis, because my occupation is such that it increases my risk to hepatitis, then I have an entitlement to get that hepatitis vaccine. That's non-negotiable. And in that particular sense, there is a question of prioritization, but there is also a question of entitlement on this. When it comes to public health, there is this whole issue of herd immunity, and I've been amazed by the meanings that it can take. So let me try to sort out the way I have sorted it out in some term. I rather like to see it as a phenomena than a strategy. Herd immunity happens whether you like it or not, but that again means I'm using it as an indicator, not as a threshold. I can say that currently the level of herd immunity in Tamil Nadu is 25%. Okay, which is a certain understanding. If it reaches 70% or 60%, herd immunity reaches a threshold at which point epidemic transition of the transmission of the disease stops. It does not stop transmission of the disease. It does not protect the remaining 30%, 40% from the disease. Therefore, the entitlement will remain, but at some point it does prevent an epidemic transition. But since this 70% is not evenly spread and the disease spreads in clusters, this is well known in malaria also. In some sense, I am very surprised that we rediscover these principles. But it spreads in clusters. Once it enters a cluster, it outbreaks into and can go expand. It may take time to build up a critical mass in another cluster, and then it moves. Therefore, even within limited situations, a certain type of contact tracing and limitation of the spread helps. In an apartment complex, in IIT in Chennai, Madras, they had an outbreak. They found the source of the outbreak. They quarantined. They effectively have deferred it for at least 6 months. They will now get to the vaccine before the virus gets to them, hopefully. So in some sense, what you have is a possibility of looking at this in a public health sense as a disease that moves from cluster to cluster, reaching saturation level. So you could have 70%, but you can find Kerala is having diphtheria outbreaks. And if you look at those diphtheria outbreaks, they are very often in an elderly age group that got left out, relatively elderly age group, but reintroduced from the pre-epidemiological transition migrants coming in over there, sparking it off within a cluster. Now, Kerala has a herd immunity for diphtheria, but it still does not prevent some major epidemic outbreaks that you have had within the last 5 years. But they are outbreaks. They'll never reach a pandemic stage, and they burn out within a particular way. So I do think that we should not, but we can't say that we are going to reach 70%. And vaccination to reach 70% is very difficult, but we can try to see communities that are more vulnerable to it, individuals which are more vulnerable to it, have a higher access and a higher awareness of accessing this entitlement of theirs. So this is a broader way in which we can construct a foundational principles on which we can construct a public policy from what we know and what limitations we know. The upsetting thing is that we don't know that vaccination, as different from an infection, prevents transmission. But it's a reasonable expectation that a person who is vaccinated is not likely to become a super spreader the way an unvaccinated person infected should be. We don't know that. But we will get to know that hopefully as we go down the line. But that sort of spoils the pitch for saying, as a public health measure, look at vaccination of most likely sources of spread. But eventually, public policy will have to move in that direction and try to see this interface between how we convert what we know into what would be a a sensible policy of how we approach a problem like that.
Okay, can I come back to the query, the discussion point?
Yes.
I would be interested in Dr. Kang's response to what I said.
All right.
This is an interesting point. I'm
Okay.
making herd immunity.
Okay.
I have
All
this
right. So
gap.
first I'll go to Dr. Kang and then to Dr. Asheel. Yes, Dr. Kang, go ahead.
Okay.
So let's start with the question of entitlement. And to me, I would actually have used the example of hepatitis B, where we give hepatitis B vaccine to everybody when we know that the risk is not for everybody. There are priority groups that should be getting hepatitis B vaccine more than others, obviously, and yet we give it to everybody. So I don't think that if an individual has, so you can also think about vaccination from an occupational perspective. Certain kinds of vaccines should be given, let's say, to nurses who work on a transplant facility that might not be made available to others. But I think when it comes to those tend to be infections that spread in a different pattern of transmission from a respiratory virus, and a respiratory virus that is unpredictable. So I think it would be, at a global level, unethical to deny anybody the vaccine. And from the point of view of a government, I understand prioritization, but I don't think that the government can walk away from its responsibility to vaccinate everybody. I think that is the government's responsibility. It needs to fulfill it. It needs to have a timeline for it. I also think, if you want to ask people who can afford to pay for it, sure, ask them. And a lot of people will. But I don't think that the government should be stratifying and making decisions about who will be a beneficiary and who will not. A beneficiary is not a word that I like very much. Now, when it comes to herd immunity, and it comes to thinking through how you get to herd immunity, I completely agree with you on the test trace, because what you said was exactly what I said, which is when it is in a limited setting, when testing and tracing has the opportunity to make a difference, it should be done. But there also comes a stage where you can't do much with the testing and tracing because you're doing it so badly, it doesn't make sense. In that situation, should you have those resources there or not? For herd immunity, again, if we take a look at malaria, that's one story. It's a disease that happens in clusters. But take measles. Are we at herd immunity?
70-80%.
Different parts of the world at herd immunity. In India, we see outbreaks of measles all the time. We are told that if we want to achieve herd, remember, measles is something that's been with us for a really long time, right? And you will continue to see measles outbreaks until you get to 95%, right? So for SARS-CoV-2, is that what we are looking for? Are we looking for a combination of infection and vaccination that will allow us to get to 70% or 80% or whatever that magic number is? And will that magic number still continue to work with variants? With measles, even though you have variants, the protection from measles is not dependent on serotype. In the case of SARS-CoV-2, we don't know that. So I think there are still a lot of outstanding questions about herd immunity.
I completely buy in that the commitment of the state should be for vaccinating all, but the notion of keeping it as an entitlement helps the larger. It's the same thing in some way. What we are saying, when everybody has an entitlement and this is a preventive measure, then at some point there is a commitment of the state to deliver it, because we are not going into the pricing mechanism at all. I'm not a great votary of that. But Dr. Asheel.
Yeah,
Yes, Dr.
just to be a person working on this vaccination or in the field on vaccinating the people, one thing which is concerning about herd immunity for us, just to share my concern, is that we looked at the seroprevalence in Kerala state, the last seroprevalence study which came out in of February, which we published a day for yesterday, which says that around 11% of the population. It's a fairly good sample size, unlike ICMR. We actually went for more than 20,000 people sample size. So which says that around only 10.56% of the population is having the seropositivity, which means our 89% of the population is still susceptible for the infection. And we were thinking, and today we were having a discussion on how are we going to reach a level of herd immunity threshold of 70% if you are actually looking at getting a vaccine immunity rather than natural immunity. So that was just a concern to share. So just on the health system part, your Don was asking about the health system. How do we see health system in the future, right?
Yeah, very quickly, Dr. Asheel.
Yeah. Let me take the quote from Sujata Rao Madam. What she says is that history gives an opportunity once in a century to strengthen the health system. Just like we had a occasion for strengthening the health system after Spanish flu of 1918. Now we have a situation where we can actually, people have started talking about public health, started talking about the issue of or the cost effectiveness of investing in public health. Just an example is that there was an article saying that if you have invested $5 billion in strengthening our public health, we would have saved around $5,000 billion. Just 1,000 times is the benefit which is expected from strengthening the health system. So when we are talking about that strengthening of health system, there was a report came by the National Finance Commission report, which says that our primary focus would be strengthening on the decentralized part of health system, that is on the PHCs, CHCs and all. I think that is the most important area which we need to focus. If you look at how in what we have done in Kerala is that we have fairly good PHCs and CHCs, which are now actually converting into FHCs. And now the investment happening in the PHC level is around just somewhere around 50 lakhs to 60 lakhs is a minimum investment happening in one PHC in the state. But if you look at the National Finance Commission grant, which says that at least 5 to 6 lakhs to be invested in a PHC, I think it's a bit grossly inadequate. So when we need to decentralized health system need to be strengthened, I must say that that actually covers in a way covers the equity aspect of that. At least the rural urban divide can be actually dealt with basically strengthening the public health infrastructure at the rural level and at basically at the peripheral level. So the Ward Health and Sanitation Committee, there is a particular, in Kerala, we had a particular ward health group, a ward health committee just for COVID-19, where the public health professionals, there would be volunteers, many things who got involved in that. So similarly, if you invest in if you ask me where to invest, then that it must be in that decentralized public health system in the periphery, so that we can have a good health systems in future. Obviously, the testing capacity, all these need to be increased. But as Sundararaman sir has said, in all those aspects, we have tremendously improved in the last 1 year, as the production of the testing kits, the facility for testing, all these are tremendously improved. But what we are still lacking is that the ad hoc system at the periphery will not do. We need to strengthen our health system starting from the periphery. Then only I think we will be having a stronger health system to deal with the epidemics in futures. Thank you.
Thank you, Dr. Asheel. Dr. Bhan, your word on the healthcare system. Yes, over to you, Dr.
Thanks, Don. So I think, certainly a lot of lessons from the pandemic, but it's not like, many of these things were not known. That you had a health system which had a lot of deficiencies was not entirely, rocket science. This is something which activists have been crying hoarse about for many years now. Can we do things differently? Certainly, in many ways. I mean, we have to address issues around our infrastructure, we have to address issues around human resources, but we also need now a health system which certainly is resilient, so that if you have another pandemic striking, that doesn't mean that either the health system collapses or your non-pandemic related health services collapse. You also need to ensure that there are adequate trained personnel available. In the front end of the pandemic, we saw a lot of scurrying around to buy ventilators or to come up with ICU beds, but nobody really talked about even if you have ICU beds and ventilators, who's actually going to run them? This is not, these are specialized services which require trained human resources who cannot be manufactured overnight, who require long-term planning and thinking. And similarly, even if we talked about contract tracing, for example, where were those contact tracers on the ground? Did states actually have these kinds of personnel? Or rather, were they just redeploying ASHAs, ANMs to do contact tracing? And what did that mean for their routine services? Similarly, when we have talked about Ayushman Bharat now so much in the public policy space, but we keep talking about only the insurance component. Why are we not questioning the status of the comprehensive primary healthcare reforms, which are also announced at the same time? How many upgraded health and wellness centers do we have? Are they really focusing on preventive, promotive services in the way they were envisaged to? What is the status of that? Are we seeing really rural health system reform in the way that we should be expecting to see by this time after the launch of that scheme? What are things? How are things operating differently? What is the role of community health officers? Are we keeping track of outbreaks at the local level? Is there efficient expenditure happening? And one element certainly is we can all keep arguing that we should increase the GDP expenditure on health, which is extremely important. But are we also spending what we have efficiently, or do state governments or even further downstream bodies get any element of funding only in December or January, and then are expected to spend everything by March? And so that means a lot of money is actually not spent or returned. So there's a whole bunch of things, which can be changed and which needs to be changed. The question is, right now we have the opportunity because of the pandemic where there's been so much of a focus, but politics and politicians and policymakers are very fickle. They just move on to the next thing. If things, if we don't enforce that, so as citizens, how do we make sure that health becomes a political plank issue, so that we expect things in the same way we expect other things from our politicians when they come to us for votes, etc. And why is it that we should not expect health and the social sector investment to remain a core government responsibility? That is one thing which should not be privatized. That is one thing where we should not see disinvestment. That is one thing where we should not see decreased investment. And even when we see investment, how is it being spent is another important. It's easy for optics to buy equipment, but then nobody talks about maintenance. Nobody talks about who's going to run it. And so you see a lot of white elephants lying in many public health facilities, fancy MRI machines which have not been used, or new machines where one critical part is missing, or lab equipment which is lying underused. So all of those are important parts of keeping a good system running. And then I think data. One of the challenges is, where is the data from Indian experience? Why do we not have a way of collating data effectively, which is epidemiological in nature, which is clinical in nature, which can be shared and be learned from, and best practices cataloged in a way? And can we do that better? Probably requires a lot of thinking and investment. So again, as I said earlier, this is not new in any way. I think many of these aspects have been talked about a lot, but now is the time to sort of see how we can do better.
Okay, thanks, Anant. And now I think it's time for us to move on to our Q&A session. So I request the participants who've been listening to us in Zoom as well as in YouTube to raise questions. Those who are in Zoom, you could use your hand raise button, and once I spot you, I'll ask you to unmute and you can ask your question. So while I wait for this, I'll quickly take a look at the chat. Yes, so Mike, go ahead.
Thank you. So this has been really, really great as a discussion. I feel very lucky to be able to hear all of this. I was wondering if I could ask Sundararaman sir about the possibilities for scientists to try to ease some of the inequities you were talking about that exist at the systemic level. So a lot of us here are philosophers of science. We are interested in the connection between science and health policy or other sorts of policies. What is it, do you think, that scientists themselves would be able to accomplish? And is there anything that a scientist could do? Should they be skewing their models so that certain populations are modeled in ways that maybe they wouldn't normally be in order to decrease some of these inequities? And what do you think?
Oh, that's a, the 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 struggle for more equity, whether in health or in the whole social fabric, something that requires a much greater participation. Now, the issue with science is that it's very often seen as happening in some neutral space, which is beyond and above politics, not as so much socially and culturally embedded. So the way in which we would, so if you are looking at, say, the characteristics of the transmission of a virus, that per se is independent of its social fabric. But how that transmission plays out, the consequences it causes, the way response is organized, this is an important transformation. And scientists need to be sort of conscious of this, how their science, their understanding converts into public policy, because at one level as scientists, they have an authority, decision makers have to listen to them, they need to come back to them, they have a level of evidence, but that doesn't really mean that the scientist is aware of the social fabric. And this interface between science and society, social phase, has been one of the most difficult challenges to handle at all times. And at some point, that particularly continues. And there's a problem from both sides on that. If you saw in the very first days of the pandemic, the TV channels were pretty skewed about who was the epidemiologist. They didn't even have a sense of who the epidemiologists are. The most outstanding clinical specialists who are in, say, surgery or cardiothoracic surgery or something would be called to comment, and they would come out with quite misplaced thing. Not that they cannot learn, but they did not even recognize that what they knew of medical practice was not enough to respond to the needs of a pandemic. So sometimes the limitations of, because you have become an expert in one area, the scientist is an expert in one area, the interfaces with social and economic thing, if they are conscious with, they can make a huge difference. I think that therefore this whole nature of a dialogue that has to be constantly there, feedback from what is happening, is a particularly important thing. And one of these key issues, part of it sometimes is handled as ethics in public health or ethics in public health science, ethics in different issues. And this interface has to be managed on that. There's no one-stop answer, but I think scientists not only need to play a role, so socially one demands that they are much more responsible of the social consequences of what they advise and how they are interpreted.
Okay. There's a question in the chat from Daniel who asks, does the panel think that night curfew is still necessary? Their take on night curfew. Daniel, I think the panelists have talked about it. Do you want something more specific from the panelists?
No, I think I even want that question to be answered.
Sure. Yeah. Okay.
At least so that I can quote an authority as saying what actually said. Yes. Dr. Kang, it's all yours. Night curfews and viral transmission.
I think it's pretty obvious that viral transmission is dependent on people congregating. Sorry, my dog is objecting to this. So, yeah, it's just about people. Wherever people are in touch with each other, there will be transmission. Where people are not in touch with each other, not in contact with each other, there won't. So if night curfews are a way of decreasing transmission, don't you think day curfews would make more sense? Because more people are out and about during the day.
And police force to enforce that night curfew spends sleepless nights on a low return activity. But they can arrest, and they killed a couple in Tuticorin also. Yes.
Can I say on this?
Yes,
we had a
yes,
we had a discussion on why night curfews should be imposed. Like in the police department, all had a discussion. Let me put it another angle of that. I don't really support that, but still, I must say that there is an explanation given to that. That is that why morning curfew is more. Yes, curfew, that is curfew per se. If you say if you have curfews in the daytime, it's practically the curfew. It's the last step to do. But night curfew actually precedes the day, full curfew. I must say that, because night curfews, what happens is that what is the logic? What the logic that the police department told is that night is the time when more unproductive interactions happen. Because in the day, the interactions are primarily of productive type, where people go for work, people go for offices, people go for these things. And night, what happens is that there is an increased chance that you will be having partying, you will be having people who the gathering which can be otherwise avoided. So the people who are going for work in the night will be exempted from the night curfew, and the people who are gathering for like avoidable causes will be got accountable. This was the explanation given by the police department, which is sense just doing a devil's advocate job here.
This is the Mullah Nasruddin story of searching for the lamplight, though he lost it in the field, because you can do it better there. You see, even on the scooters, when you are driving in a two-wheeler with the mask, the policemen are out there stopping you and arresting you. When you are going through with a mask on a scooter, there's no chance of spreading it into the environment. But when you stop to pay the fine, then of course you can spread the disease. In fact, at that time they take off the mask and they talk and why. So many of the restrictions imposed are completely independent of any evidence on social mixing, and much more are hunches of administrators than real meaning on that. It doesn't make sense. That's the long and short of it.
So there's a question in the chat from Dr. Ritu Sharma, who asks, what can be done to vaccinate bedridden and aged people who are at homes, old age homes? Managing ambulance and private vehicles can't be afforded by all. To reach the last person to vaccinate, old age people are also countable. Does anyone want to? Yes, Dr. Asheel.
Kerala is doing that.
Yeah, we are actually doing that. What we have done is that we have mobile units, that 102 mobile units we are having, where we go for vaccinating at the homes. As I said, there are 619 care homes, where there are around 20,000 elderly who are there. So that is one way of doing that. And next level, we are in one district, we are piloting the care at home. So that is delivering the vaccine at home. So what happens is that when we are going for vaccinating at a home, so what happens, we need to observe them for another 30, as per the protocol. After vaccination, we need to observe them for 30 minutes. So the mobile unit has to stay there in their home for 30 minutes to see that there is no issues. So that is the practical problem here. But what we are doing is that we are increasing the number of team to see that now we'll be covering the entire care homes by tomorrow. Actually, by tomorrow, the entire care homes, that 20,000 people in the care homes will be covered. That is basically taking the mobile unit over there, 102 mobile units. They're sitting there and they are doing the vaccination. Now we will be extending it to people who cannot actually come to hospital or not in care homes. They are the people who are actually under the palliative care program of the state. So so that comes to in a few lakhs. So that people, how we are going to do is that we are engaging teams where they will go to home, sit with them for half an hour, or leave a person over there, a nurse over there, to see that there is no complication. So such type of network is happening. The piloting of that at-home activities, that is to residences, to the people who are bedridden, single people who are bedridden in homes, that is being piloted from day after tomorrow. But by tomorrow, we'll be covering all the old age homes. So that is done through mobile intervention units on ground. So the to be put in that, the state must do that. To be in a single, putting into a single word, how do we can do this? State must do that, and states must be given enough freedom to do that. That's exactly the problem I was mentioning. When we go for the homes, we need to get mobile numbers from one mobile number. You will be able to do only for 4 people. So that issues are rising. Such practical issues need to be resolved. But that's freedom need to be given to the states for doing it in a decentralized way. So that is my experience on that.
We have a question, I guess this is for Professor Kang. Given the choice, which vaccine should one opt for out of the two?
Whichever one you're offered.
So there's a question from Jamie. This is to Dr. Asheel. And Jamie would also like to hear from the other panelists if they would like to pitch in. I'm wondering that given all the contingencies and special circumstances you're dealing with in increasing vaccine availability in local situations, what sorts of ways can more central regulations / mandates / priorities aid or inhibit your local policies? Dr. Bhan, would you like to go first?
I think it would be.
Sure, I mean, I can try. So I think one of the things which is important is we don't need a situation where states are competing with each other. So I mean, we need to have mechanisms where states are working with each other. In fact, if we look at it from a health perspective, the fact that states potentially would be at the mercy of central guidelines being contradictory to some flexibility also is something which is a concern. So Asheel, I think, already highlighted that. So what we need is probably central clarity on what are the approaches, and they need to be based in evidence. I think that's really an important role for the center to play. But I think you need to have state level innovation happening. The states should be looking at their own data and being able to respond in a more efficient manner. Everything cannot be driven by Delhi. And I think that is where being able to work across states and in terms of center-state relations, we need that to happen. I also want to maybe loop back to some of the earlier questions, which one of the challenges I think there's been an overt focus from a policy perspective on optics. So I see all of these, the night curfews, the way, you have police bandobast, etc., as mostly being wanting to show that we are doing something. And in many ways, some of the lockdown responses were that as well. And that is troubling. And it is also troubling because it links to also what Mike's question was, what is the role of scientists in this? And the role of scientists is to stand for evidence and to be very firm about saying that, we are supportive of X and we are not supportive of X, of Y, because it is not based in evidence. And that, if you come up with prophylactic therapy for everyone when there is no evidence for that, or when you say that you can come up with a vaccine in 6 weeks and it will be available and announced on a particular date, it is not based in evidence. When you announce a policy decision where there is no clarity around that, how that decision was taken, that you need to question that, because as scientists, we need to focus on the integrity of science and serve as vanguards of protecting that. If we are not able to do it, and if we just capitulate in, then who else will stand up for those values? At the end of the day, we have to be trained. We have been trained in looking at evidence from a skeptical eye, and then making pronouncements. So if scientists don't do that, and fortunately there have been some science academies or science groups which have stepped up to the plate, and others have not, and that is something which is deeply worrisome, because that also impacts the trust in science and and the way people perceive what the role of scientists should be. So besides actually doing good quality science, we also need to protect how science is perceived and how science is evaluated. So that, I think, is also an important part.
Yeah, Dr. Asheel, would you like to go?
I think Sir has already clarified it and clearly mentioned it. And I think the final details of that I have already mentioned in the, I think it will be repetition of what I already said. So I think Anant Sir has clearly made it to the point.
Dr. Sundararaman, would you like to add anything?
No, I think Dr. Anant has summarized it very well. He's exactly put it clearly. That point is well taken on that, the particular role that evidence has.
All right. So now I'll ask, Tarun has raised a hand. Yes, Tarun, please go ahead with your question.
First of all, thank you all for a really insightful discussion. I wanted to ask about, we've been discussing a lot about national inequities, but I also wanted to ask about the very stark global inequities that we're now seeing in terms of vaccine distribution. And specifically, I mean, many lower income countries are really struggling to vaccinate even very, very small proportions of the population. And my question was, how much of this do you think is attributable to aspects of our global intellectual property regime? I know there are questions being raised about a potential waiver for intellectual property for vaccines. Would that make a significant difference in terms of dealing with these global inequities, or is this a deeper problem than that?
So, well, this is one area where I am currently very much engaged in. The move for a waiver of the intellectual property regime from the resolution actually moved by India and South Africa. It's actually won very wide support. The least development countries have come in, the WHO has come in favor of it, UNAIDS has come in favor of it. It's built up a considerable degree of support. Having said that, the core of the industrialized countries, which have the market in command, the US and for the European Commission, and even Canada, Australia, Switzerland very actively in this, are standing quite steadfast against it. The waiver is one part of it. Okay, so that's one larger issue there, the whole intellectual property regime. But the other way is how the global supply chains are acting out. And the third issue is the transfer of technologies. So even if you do waive the patent regime, most of the countries will not have the capacity to undertake manufacture of vaccines, much less on this scale. So therefore, it needs to go along with the transfer of technology, which sometimes can be equally different. Because if it was only a question of waiver, though it's more difficult to operate, the TRIPS flexibilities could have been used. Potentially, the TRIPS flexibility allows in a public health emergency, it will be case by case, medicine by medicine, country by country, whereas a waiver cuts across. But if you go that way, a country like Nigeria, for example, could exercise but then the manufacturing capacity and the transfer of technology that needs to go along with it and things. So the question is, we are in a cusp of an issue where we are talking about this whole free trade, globalization regime, intellectual property right. All of that stands in a crisis. And the crisis is not only now between us. UK is likely to go into a major crisis if the European Union cuts off its vaccine rate of supply to UK. That's a crisis that is ongoing today. So there are between those countries also a lot of now AstraZeneca is trying to develop manufacturing hubs in Argentina and South Korea other than India, and therefore is trying to show that it is trying to cut off the pressure that is developing for breaking with this regime. And to what extent they will succeed, we don't know. But really, this has, in terms of vaccine access and in terms of access even to diagnostics and other goods, this is really shown that the global supply chains are not able to deliver, that patents are a barrier, and the lack of transfer of technology is crippling. India is relatively better placed in this. It's really the other countries which are even more at the mercy of the global distribution.
We have, I think, time for two more questions. So this is from Mike for Dr. Asheel. So Mike asks, is Kerala's relative success with the pandemic related to differences in public attitudes towards marginalized populations? To address inequities in other states and at the national level, do we need to change all of public opinion, or just the opinions of the politicians, or the politicians and the scientists, or somewhere in between? Whose attitudes matter?
Everyone's attitude matters, and primarily I think of scientist attitude matters. As Anant sir has rightly put, what do we agree to be science? For that really matters. because it's as scientists, it's our duty to actually improve the scientific temper of the whole nation, and that includes the politicians also. When we say that the clapping hands, I must be very specific in that. I must say that clapping hands, lighting lamp would actually prevent. If that is done in a solidarity, it's okay. When you say that would actually decrease the incidence of cases, that is something the scientists must object to. And when someone comes with a bizarre medicine and say that this is the solution for that, the scientists must be able to stand and say that it's not the truth. So I think the attitude primarily of the scientist matters here, and the scientific society to per se. And I must put it very sadly that the scientific temper of the scientific society, what we call a scientific society in the nation, is so poor that it doesn't really understand, actually differentiate what science is and the politics of science. So what happens is that when someone says that, see, this is at the first time the ICMR stood against it, what I think is that when Gomutra was asked to test against, I'm sorry, I'm being very specific in that. Gomutra was supposed to be tested for COVID-19. Then it said that, yeah, that's it. We cannot actually do that. So that level of scientific temper, that must be actually, the level of scientific temper must be improved at all levels. And when the government should ask the scientific temper of the government starts, or the politician starts, when they take the opinion of the scientist in that and go for evidence-based policy making in that. And for that to happen, I think it's a primary role of the scientist to improve the scientific temper of a society as a whole, because everyone, even the politicians, everyone actually reflects, it's our cross-section of a society. So just to put it like this, how do we, when you say about inequities, as Sundararaman sir has rightly put it, where do we have actually, how do we see this? Are you seeing it as a law and order issue? Are you seeing it as a socio-economic issue? Are you seeing it as a public health issue? Or are you seeing it as a medical issue? So that every angle of that matters. How do we actually develop that? In order to develop that, the scientific temper of our scientific society, especially the medical background, people in the public health, should understand that your decision in policies, your decision to lock down, your decisions to make all the interventions what you make in decisions to control the disease is actually affecting the people disproportionately. So how do you address these inequities? That need to be part of the science also, because the sociology, basically the sociology and the anthropology also need to be incorporated to our understanding of public health and medicine. So that I think the primary role, whom should be sensitized, is the scientific society of the nation to be put first, and everything starts from there.
So we have one question from Dr. Ritu. During the pandemic, the healthcare attention was fully on COVID. It deviated attention from already existing interventions with regard to NCD, CD, cancer, TB, Ebola, etc. Public health sector got affected, and so many people are neglected, and there's a huge gap between what can be. So she asked what can be done to overcome this gap. So perhaps I'll add on something to it. Yes, Professor Kang needs to go. Yeah, sure. Thank you so much for being with us. Yes. So perhaps I'll direct this. I think we've covered Dr. Ritu's question a bit. Does anyone want to pick up something from there? About the gap that Dr. Ritu is asking about.
If Sundararaman sir is not responding, then I will.
No, could you just, I was getting, what is the gap you are mentioning on this, the gap?
So there's a gap between, there's an undue attention on COVID, and that has sort of taken away the attention from other diseases. So I think that's the gap.
Let me put it this way. I would phrase it differently. I would say not that there is an undue attention. People have died. In the West, this has been the second largest cause of death. In India, it's the 18th. In some months, the deaths were more than September. COVID-19 is a serious health problem. It's a serious public health issue. But the fragmented approach, the uncoordinated, a non-systemic, a lack of a systemic approach where you targeted one disease without looking at its interconnections to the rest of the health systems, is the core of the problem. So the call is not against so it's the point is not an undue emphasis, but a lopsided emphasis. An emphasis which was not balanced, where it could not take along the other areas. Let me give you an example. One of my friends in the science movement, Dr. Madan Mohan Pradhan, is joint director in malaria program in Orissa, and he looks after the Malkangiri district. He noted in the month of March, April, a recrudescence of malaria in 34 blocks, and was quick to find out that what had really happened was that all the malaria workers had been repurposed to be looking at COVID-19. He has taken a huge amount of effort and that whole team to have made Orissa a great success story in malaria control. The last few years has seen one of the greatest decreases in malaria, and they felt threatened for their program. It's the same like the Biratnagar Express. They responded it to going there, making sure that every field worker did not do COVID-19 control without malaria or malaria without COVID-19 control. After all, what do you do in malaria? You look for any patient with a fever, and if it's a fever, you do a RDT for malaria. You do a rapid diagnostic test. Now you have to add on to it a rapid diagnostic test for COVID, and you have to put that particular patient to a certain degree, and you have to have a follow-up, and you have to have an hospitalization. There was no fundamental reason, and therefore, in their COVID-19 testing camps, they introduced RDT testing. Sri Lanka did the same thing. And they found a lot of malaria, some 5,000 cases of extra malaria they discovered by pitching it along with the fever camps for this. So the point is that there is no inherent reason why you had to shut down the other treatments for this. It is a certain degree of non-thinking, a certain degree of an administrator mindset who says, okay, I'm doing this, stop everything, do this, not understanding a systems approach of how you can integrate. I won't put it only to the general administrator. Some of our medical technocrats can be as bad, but there were technocrats, more out of the passion for what job they had been doing. A gynecologist who says, how can I let all these pregnant women depending on me without care? And she advertised on the radio that care continues. We haven't stopped our hospital, allowed access to care, and developed a separate COVID-19 channel for that. So there have been people who have been passionate about just passion, because the rules were not really there. We've published a paper on this, and we've got some best practices on this. But the point is, it's a lopsided importance rather than the way undue seems to lessen the magnitude of COVID-19. I'm not one who would say this is just another flu. It's not.
Can I add to that? I think in addition to what Sundararaman sir has said, there is another positive externality also in, focusing on COVID control from our experience in the state. We were looking at the all-cause mortality, looking at the excess death analysis. For comparing with the 2019 one-year data, we compared with the all-cause mortality of 2020. What we found was, surprisingly, we had around we had around 10% less deaths in 2020 when compared to 2019. That is, excess death analysis actually revealed that it is 10% less deaths in 2020 compared to 2019. So that there are countries where it's 14% extra deaths. There are countries, for example, US, there is 14% extra deaths. In France, it's 8% extra deaths, and that is excess deaths.
But then, I'm going to take a rain check on that one, and the jury is out on that one. We've been also looking at a study. We are very worried about what's happened to death reporting in this interim. There's been a problem. There's been a problem across the board, and we'll keep our thing open on that. I think
this is data based on the registration of deaths, sir. That's a death.
There is a real problem on the registration of deaths that is ongoing on this. There are many across some of the weaker states. The problem is even more rapid. You can't have such a low death rate in some of the states which are reporting such low death rates now. Now,
And not looking into the case fatality rates, sir, not looking at the particular the definition of the deaths, but just looking at the all-cause mortality that is basically based on the registration at the local self-government. So every death has to be registered within 21 days of after occurring the deaths. So that is the registration which is happening. We were looking at what there are positive externalities of the control. For example, wearing mask, following the physical distancing and the hand sanitation would have actually have had another effect on. For example, we're looking at the TB incidents. There are many respiratory infections and diarrheal diseases which came down during this when we actually followed the this break the chain guidelines, that is social distancing, masking, and our hand sanitation. So there is another positive externality. I'm not getting the details of that. So then there also, as Sundararaman sir has rightly pointed out, where the hospital facilities, when the hospital facilities were put on exclusively for COVID control, there were gaps in addressing the non-COVID cases. So another part is that whether we need to look at another data is that whether the nosocomial infection, the hospital-driven infections, or the infections happening in the hospitals, or deaths happening at the due to nosocomial infection, that is hospitals infections at the hospitals, are actually also decreased. So there are the COVID control, the COVID, the public health infrastructure, the public health activities which came as part of COVID control would have a positive externalities also, but the focus, the unscientific focus on exclusively on COVID control, as Sundararaman sir has said, would have actually led to setting the focus out of other major diseases.
Gentlemen, I'm afraid we'll have to stop. It was wonderful to have this discussion. There's actually a good question from Jamie, but I request Jamie to send that question over to the panelists separately. It was fun doing this, and I hope this program has gone a long way in elevating our worries about the pandemic and made us more optimistic about its proper management. I thank all 4 panelists and those of you who have tuned in to listen to us and ask questions. Thank you so much.
Thank you. Bye-bye.
Bye. Thank you.